It's my great pleasure to introduce our distinguished speaker, Dr. Jahid Khan. Uh, Dr. Jahid is a consultant medical oncologist at a renowned Clatterbridge Cancer Center NHS Foundation Trust in Liverpool, UK. His extensive medical journey began with an undergraduate degree from Chittagong Medical College in Bangladesh. He then completed his postgraduate medical training in Leeds and specialized in medical oncology with further training in Sheffield. Currently, Dr. Jahid is based in Liverpool, where he focuses on treating the colorectal cancer and the testicular and the germ cell tumors. His commitment to improving the patient care is evident in his role as the lead of the colorectal service reference groups in Clatterbridge Cancer Center. Dr. Jahid's passions for training and education shines through his in various roles. He is a valued member of the Specialty Training Committee of Health Education in England and contributes significantly to the education team at the Clatterbridge Cancer Center. Additionally, he serves as a guest faculty member for the MS Urology course at Edge Hill University and holds a title of Honorary Clinical Lecturers and the Faculty of the Health and Life Science University of Liverpool. Today, Dr. Jahid will be sharing his insights on a crucial topic, molecular information in colorectal cancer, a surgeon's perspective. In this talk, Dr. Jahid will delve into the molecular underpinnings of colorectal cancers, offering a detailed exploration of how these insights can inform and enhance the surgical practices. He will discuss the latest advancement in molecular diagnostics and their implications for the treatment strategies, providing a valuable perspective that bridges the oncology and the surgical disciplines. We are honored to have Dr. Jahid with us today and to share his insights and expertise. You are welcome, Dr. Jahid, to our today's webinar, and thank you very much for joining us today. Today in this sessions, we have a distinguished general surgeons, colorectal surgeons, medical and the radiation oncologist. I hope you will enjoy the share your slides. Dr. Jahid.
Thank you very much. সবাইকে সালাম। I'm mindful যেখানে মারগুপ স্যার আমার টিচারও আছেন এবং আরো অনেক সিনিয়র সার্জনরা আছেন। They are all trainers and I hope this will be helpful for the trainees today. So as I said at the beginning that today's lecture is more about clinically oriented, so I've tried to avoid significant scientific information or literature review, and it's just to summarize what probably the trainees need to know more than anything. Now, I didn't know that there will be a quizzes. I'm afraid I also prepared a few quizzes for the students, and I'll give a few seconds for each slide. And once I finish my presentation, I would like to come back to these questions again, and just to hear what the trainees think about the answers. So the next question.
First, you share your slides presentation.
Is it not coming up?
No.
Oh, okay, all right. Okay, I'll try again.
Okay, now.
Just let me know when it comes up.
Yes.
Has it come up now?
Yes, clear. Okay. Please.
Thank you very much. So some of the questions that I prepared that I thought will be clinically relevant. I think this is probably what the surgeons will see on day in and day out. So the first, and at the end of my presentation, I will come back to these questions again, so that we can go through this together. If the trainees, if you'd like to just make your own notes, what you think about these statements, and then we can discuss at the end. So there are only 4 questions, which I think probably covers most of the situations that the surgeons is likely to encounter. So I took this lecture exactly in the same way for the surgical trainees in my region, and let's see how if it is helpful or if we need to do any change or modification, then I'll certainly think about it in future. So any molecular information, why do we need the molecular information? That's the very first thing to keep in mind. Yes, we get a diagnosis by investigations, by colonoscopy, by imaging, by biopsy. We get a confirmation, we can stage the patient. Then why do we still need molecular information? Because they give us two very important information. One information is how the cancer is likely to behave, and that's what we call the prognosis. And that is independent of how even you are planning to treat it. Okay, so we know that right-sided primary is unfortunately offers a poorer prognosis stage by stage compared to its left-sided counterparts. We know that in stage 2 colorectal cancer, if it is deficient MMR, then their prognosis is actually similar to those with a proficient MMR and who also had adjuvant chemotherapy. Now, the information can be something that gives us what treatment is likely to be helpful or what treatment is unnecessary, and that's what we call the predictive information. And again, sometimes same information can be prognostic and same information can be predictive, like the MMR. So we talked about that deficient MMR in stage 2 is a good prognostic information. And we also know that in this group, the neoadjuvant or adjuvant chemotherapy doesn't really offer any additional benefit. So which means that we can avoid patients from not only the clinical toxicity and the complications of chemotherapy, as well as the financial burden as well. So let's look at the standard information that we look at. The reason I'm saying standard, because there are many commercial extended panels available where you can look up to 400 genes assessment. The question is, we don't need all of them. On a day-to-day practice, we only look at what's actionable and what is not actionable. So the information that I've put up here, these are all actionable information because all of this information will give us either the information about the prognosis or the prediction about a treatment success or failure. So one of the most important, and if I can say probably the most important information in colorectal cancer, particularly for surgeons, is the MMR or the MSI status. And it is variable. In stage 4, we get the lowest percentage, roughly about 4 to 5%. But actually, as the stage is lower, your likelihood of getting a higher percentage of MMR. So in stage 2, you can get up to 20% of patients who can be MMR deficient. And in stage 3, it can be up to 10 to 15%. And then the rest things we look at is the RAS mutation. And again, there are two codons that we look at, the KRAS and NRAS. The KRAS is roughly about 40 to 45% mutated. KRAS and NRAS both are what we call a poor prognostic information. So if patients has got any of these two mutation, their cancer is likely to behave more aggressively. They are not going to respond to the EGFR targeted antibodies. And again, when you just think about the prognosis, the RAS mutated patients has got a poor prognosis compared to RAS wild type patients, no matter how we manage them. Another poor prognostic information is BRAF mutation. Fortunately, it's only about less than 10% patients who have BRAF mutations. And in the past, when we did not have a BRAF targeted treatment, unfortunately, most patients would die within 12 to 18 months. I'm talking about stage 4. A smaller proportion of patients can be hard to amplified. And again, it's a predictive information because when someone is EGFR, when someone is RAS wild type, but they are hard to amplified, then unfortunately EGFR antibody doesn't work. They have a resistance to this treatment. But again, on the other hand, if you treat them with hard to targeted treatment, then they have a significant response and improved survival. So PIK3 is again negative prognostic as well as the predictive information. If you have PIK3 mutation, they behave very aggressively. And also EGFR targeted treatment doesn't work, even though the patients can be RAS wild type. And a very small number of people can have NTRK fusion, and they can respond very well to the NTRK targeted treatment like entrectinib or larotrectinib. So these are, I mean, as I've said, there's a plenty of other information that we can learn and we can see. But when it comes to what's really relevant at the moment, as we speak today, these are the commonest molecular information that we will look at. Now, let's very quickly go back to this is probably from our third year pathology lecture. I think most of us will remember this, that the cancer is a multi-gene hit process. You have to have something that will go wrong first. So in colorectal cancer, in the vast majority is the APC. And the APC, when it stops working, then you start to have the dysplastic epithelium. Then obviously you need a second hit and a third hit, genetic hit. And all of these will lead to the adenoma carcinoma sequence, leading to the full-blown cancer as well as the metastasis. Now, all these processes can take a very long time, and anything between 10 to 15 years will take for a cancer to develop in the traditional adenoma carcinoma model. But over the years, we also learned that there are actually far more established carcinogenesis model that we know. So if you look at the right side of this picture, it looks very complicated, but let's break it down. So if you look at on the right side, which is the conventional pathway that we know, which is the typical adenoma carcinoma sequence, you've got APC gene mutation, and then you get their hypermethylation, KRAS mutation, loss of homozygosity, and all of those will lead the adenoma to the carcinoma. One thing to keep in mind, these are all microsatellite stable at the end. And if you have the APC gene mutation as a germline mutation, which means you have inherited from your parents, then you get the FAP or the familial polyposis pathway, where they will develop thousands of adenoma at a very early age, and that can lead to cancer. Now, let's look at on the very left side of this column, where we are looking at relatively, when I say relatively, it's been established even for decades now, that now we are looking at. So what we look at on the right side, this is the chromosomal instability pathway. And now we are looking at is genomic instability pathway. So what happens here, that we have DNA mismatch repair process, which is supposed to take care of the spontaneous mutations that happens in our body. But when the DNA mismatch repair system is not working, then we'll have an accumulation of abnormal DNAs. And those abnormal DNAs, when they replicate, they will increase the burden of more abnormal DNAs, and that leads to the cancer process, okay? And that's how you get the microsatellite unstable tumor. And again, if your DNA mismatch repair abnormality, if you inherit as a hereditary manner from your parents, then you get the Lynch syndrome. So the Lynch and FAP, these are the two well-established familial stroke hereditary pathway of the cancer. And rest of the all other pathways, these are sporadic, which roughly 80% or more that we see in our daily practice. So let's keep this information, because we're going to apply this information later on. So let's understand with MMR and MSI. So MMR stands for mismatch repair, and the MSI is microsatellite instability. So we do have this, what we call a baseline mutation, spontaneous mutations that's happening along our genome all the time. And we have this DNA mismatch repair system, which is basically managed by 4 genes, the MLH1, MSH2, MSH6, PMS2, and they produce the corresponding proteins. And these proteins are responsible that when the DNA polymerase is cleaving the DNA, replicating and causing some problems, these proteins will recognize the faults in the replication, and they will correct it. If the genes are normal, then the proteins will be normal. If the genes are abnormal, the proteins will be abnormal. And that's the basis of the MMR test. The pathologist is trying to stain these proteins in the tissue. And if all the proteins are taking the stains, indicating that they are present and they are functional, then we also assume that the MMR genes are also functional, okay? Now, as I've said before, that when you have the abnormal protein, and which means that this protein is not going to function, and then what will happen, that it will lead to faulty replication in the daughter cell. And I'll come to what the satellite is. And this will be, you can capture those when you assess a tumor and you look at the satellites, the microsatellites area, and you see that they are not normal looking, they're different than what should be normal, then you can call a microsatellite unstable. That's what the other term that we use called microsatellite high. Now that brings another question. We keep talking about this microsatellite. Now in the in our genome, it's composed of thousands and millions of DNAs. I think there are about 4 billion base pairs. Now in the genome, there are certain parts of the DNA which are repetitive in these base pairs. And this is what is called the satellites. Why it's called satellite? Because it's an historical term rather. That if you centrifuge DNA in a test tube, there'll be a major bulk of the normal DNA, and then there'll be some separate layers of DNAs which are composed of these repetitive bases. And these are at that time, the scientists called it satellites, and there have been further names like microsatellite when it's about 1 to 6. It can be mini satellite when it's more than 10 base pairs. Now, this is actually a little bit more unstable area normally in our genome. And because they're repetitive, when the DNA polymerase goes through and tries to replicate, they can easily misread or they can slip. And when they do that, they will either create more bases or they will create lesser number of bases in the daughter cell. So you can have the microsatellite that can be longer than normal, or it can be shorter than normal. And it's like a chain reaction. Once it happens, each daughter cell will have more abnormality compared to its parent cell. And that's where the term comes unstable, because it's now genetically an unstable situation where each successive cell division is creating an increasing burden of abnormal cells, and that leads to the tumorigenesis. So there are 3 ways to assess this abnormality. There are 2 well-established. One is the immunohistochemistry, which looks at, as I've mentioned, the presence of the MMR proteins. And if they are taking the stains nicely, then the pathologist will call that all the proteins are present, and the possibility of an MMR abnormal expression is not there. Which is actually quite quick, less expensive compared to the MSI test, which is done by PCR, which is polymerase chain reaction. So you need big labs and machines, which compares these microsatellites of the tumor and the microsatellites in the normal tissue compared to some standard panels of microsatellites. And if they see that there are increasing number of abnormal microsatellites, then they will call as a microsatellite high or microsatellite unstable. Now, next generation sequencing is something that is taking over at the moment. The benefit is that, as I've said, that if you look at the commercially available molecular panels, they look at 300, 400 genes at the same time. And this is done by the next generation sequencing. So obviously it's horribly expensive, and it also takes longer time. So the shortest and the quickest way to get this result done on our patients will be the MMR test. So just to summarize, we are looking at 4 MMR proteins when the pathologists look at. And in the MSI test, the machine is looking at how many abnormal microsatellites are there. If there are less, if there is none, then it's normal, or the other way to call it microsatellite stable. If they have a few number of unstable microsatellite markers, then they will call it low. And only there are 2 or more, and that's what we would call it microsatellite high. And there is incredible concordance between the MMR and MSI, and which means that we don't need to do both the tests in the same patient. One test is enough, and it's become a standard in UK to do only the MMR test. And one of the added benefit of the MMR over MSI is that when you see one particular protein is missing, say for example, MSH2 is missing, then you know straight away is the MSH2 gene which is not functioning, whereas you will not get that information from the MSI test. So I've just put up a few reports. This is what it looks like when you look at the MMR report, that the pathologist will mention whether the proteins are showing normal expression, where or any of the proteins will show any abnormal or lack of staining. So the top report is a normal report, and the bottom one is what we would call an abnormal report. And the accepted terms is proficient or deficient. So in a normal MMR result, the term that we'll use is proficient MMR, and in the abnormal MMR, the term that we use is deficient MMR. And if you look at the MSI reports, this is how we get reports in UK, that the lab, the genomic lab, will do the PCR, and they will tell us that it's no evidence of microsatellite instability. If there's only one marker, then they will call a microsatellite low. In a microsatellite low tumor, just to keep in mind that immunotherapy has got no role. We only need MSI high tumor, which means that it has to be present in 2 or more microsatellite panels. Now, if you get an abnormal MMR result or an abnormal MSI result, again, this is not within the scope of the surgeons to do. Then there is something else that we need to figure out: is it sporadic, which means that has it happened in the patient without inheriting from their parents, or is it actually a germline mutation which the patient has inherited from their parents? So if you look at if you got an abnormal MMR, sometimes it is easy to understand. Again, I could be complicating it here. If you have MLH1 and PMS2 deficiency, then you have to do the BRAF mutation and the MLH1 promoter hypermethylation to check whether it is sporadic. If you get MSH2 and MSH6, you can straight away tell that this is a germline mutation. So again, another benefit of the MMR testing. However, if you do the MSI testing, it doesn't tell you, number one, which gene is abnormal. And also, I'm afraid it doesn't tell you whether it is sporadic or is it germline. And again, you have to do the BRAF mutation test as well as the MLH1 promoter hypermethylation. And if both are absent, then you can say that this is likely to be a germline mutation. Why do we need to do this test? Because we want to pick up the people who's got Lynch syndrome. And as you have already seen in the quizzes before, that this is actually the commonest hereditary reason of the bowel cancer. We used to know by its previous nomenclature, which is hereditary non-polyposis colon cancer, just to separate it from the FAP, but the Lynch has become the more standard name for now. It is an autosomal dominant condition where there's a germline mutation in one of the MMR genes or the EpCAM gene. And there is a significant lifetime risk of colorectal cancer as well as other cancer. And more importantly, there is a significantly increasing accumulative risk of colon cancer if the patient lives, as you can see, 10 years, 20 years, and 30 years from their diagnosis. And there is also risk of extracolonic cancers. So keep in mind, the endometrial cancer is the commonest associated cancer or Lynch-associated cancer. But people can have other GI tract cancer and the urinary tract cancer as well. And there are some skin manifestations. Sometimes they can give away as well about the possibility of Lynch syndrome. It is important to consider that the colorectal cancer surveillance in Lynch patients is separate and different compared to the normal population. And also to keep in mind that the surgical approach can be very different as well when we know someone has got a Lynch syndrome or someone who's got a very strong family history of Lynch syndrome. Now, how do we apply in the clinical care? And this is what is very important, and I'd really like to keep attract the trainees' attention here. This is probably the most important slide in my whole presentation. So keep in mind that the deficient MMR patients tends to have a better prognosis compared to the proficient MMR. their tumor attracts a high degree of lymphocyte, tumor infiltrating lymphocytes in the body, and their metastatic potential is lower in that perspective. And we talked about in stage 2 bowel cancer that a proficient MMR patients and the deficient MMR patients, their prognosis is different, and the deficient MMR prognosis their prognosis will be better compared to the proficient MMR. We also know that there is a degree of resistance to the fluoropyrimidine chemotherapy, which is the backbone of colorectal cancer treatments, and there is no benefit in single-agent adjuvant 5-FU or capecitabine in neither stage 2 and not stage 3. Over the years, we have found out that the deficient MMR or the MSI high patients, they have incredible response to immune checkpoints inhibitors. And there is a very growing argument that if the primary cancer is MMR deficient, do they need surgery? Do they need chemotherapy? Should they only get the immunotherapy as their sole treatment? And I'm afraid this is an ongoing debate. So keep in mind in the early stage, and this is what you're likely to manage as a surgeon. But if you're managing a late stage cancer, the deficient MMR, they are suitable to be treated by immunotherapy, and which provides a significantly better response rate. Just to give you a perspective, that in deficient MMR, the chemotherapy response rate is 10 to 15% lower than the proficient MMR, so roughly about 20 to 30%, whereas the immunotherapy response rate is about 60 to 65%. The overall survival from the Keynote trial 177 is actually now 6 years, the median survival, which is amazing. This is the best prognosis that we have seen so far in colorectal cancer in stage 4. So the other targeted treatments which are in practice, you are aware about the immunotherapy in deficient MMR patient, EGFR targeted antibody treatment in people who are EGFR wild type or no mutation, and people who are EGFR mutated, then there is no role of an EGFR antibody, but there is evidence that the VEGF antibodies can actually provide an improved response rate as well as survival. The HER2 targeted treatment is gaining field, and we talked about it before. The patients who are HER2 mutated, they have a really good chance of responding to HER2 targeted treatment, and there are quite a few that's been approved by FDA. However, as a surgeon, what role do they play if you're going to operate a patient, whether it's for primary or secondary? Actually, the answer is very simple. That the rest of the molecular information, the KRAS, NRAS, BRAF, HER2, there is actually no significant value at the moment as we speak today in surgical decision making, whether you're talking about the primary tumor or whether you're talking about in metastasectomy. The only exception is when there is a patient with a known Lynch syndrome diagnosis. So let's bring back to these questions. I'm afraid I do not have any interactive way to get these answers through the app or through the Zoom, but I need some volunteers. So anybody who wants to answer, please come forward, and do not feel any way awkward if you're not sure if you're giving a wrong answer. So the first question, that you've got an operable non-metastatic patient, very fit, no contraindication of surgery, and it is easily operable from the imaging, and there is no question of neoadjuvant chemotherapy here. So which statements are true? A, patients need MMR, MSI, KRAS, NRAS, BRAF results before surgery. Would anybody like to answer?
Any students, please speak out. Any student? যে কেউ বলতে পারো. Anyone can participate. Yes.
If you use the chat box, that's fine too.
Yes, বলো.
Option A is sir. Question number 1, sir. এখানে sir patient need only MMR, MSI result before operation. I think that's the truest statement, sir. Because sir patient need MMR, MSI, KRAS, NRAS, BRAF. MMR, MSI ঠিক আছে স্যার, কিন্তু KRAS, NRAS, BRAF metastatic colorectal cancer হলে আমরা এটা করতাম স্যার। আর র্যাস বিরাপ মিউটেশন যদি করা হয় স্যার, এটা পুর প্রগনোসিস ক্যারি করে স্যার। আর এমএমআর এমএসআই টেস্টিং হেল্পফুল আফটার অপারেশন হোয়েন অ্যাডজুভেন্ট থেরাপি ইজ কনসিডার্ড স্যার। এটাও স্যার অ্যাডজুভেন্ট থেরাপি, ওই স্যার অলরেডি বলেছেন স্যার, ফ্লুরোপাইরিন বেস কেমোথেরাপি কাজ করে না। আর স্টেজ টু তে যদি এমএমআর এমএসআই হাই থাকে তাহলে অনেক সময় অ্যাডজুভেন্ট থেরাপি দেয়। কিন্তু স্যার ওই এমএমআর এমএসআই রেজাল্ট বিফোর অপারেশন স্যার, এটাই নো মলিকুলার টেস্ট ম্যান্ডেটেড বিফোর অপারেশন, এটাও ফলস স্যার। স্যার
আচ্ছা, এ
সি,
এ আর ই হচ্ছে ফলস আপনার মতে, আর বাকিগুলো হচ্ছে ট্রু।
স্যার বিটা হচ্ছে পুরো প্রগনোসিস ক্যারি করে স্যার, এটাও ফলস স্যার।
এটাও ফলস। আচ্ছা
জি স্যার।
আচ্ছা আচ্ছা, থ্যাংক ইউ ভেরি মাচ। আচ্ছা 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 স্যার, আর কেউ কোনো রেসপন্ড করবেন? Remember, please, it's a discussion. That we can be wrong, and that's absolutely fine.
Yes. Ahad ibn Anas কি বললো? সি ইয়ার আনসার।
Assalamu alaikum, sir.
ডক্টর আহাদ।
As MMR or MSI can give the information about the immunotherapy, which can use after operation, or sir already mentioned that it is debatable that MMR immunotherapy can also overcome the surgical up down. So MMR MSI result before operation may possible the answer. KRS and RES BRFs are already mentioned that there is no role before surgery, and obviously a no molecular test mandatory before operation is false statement. I think C is the appropriate answer.
Actually, some of the good, I've heard a few good arguments, but I will respectfully differ with the. So let's start with the very first one. The patients need MMR, MSI, KRAS, NRAS, BRAF. So we talked about it, that the MMR, these are all predictive and prognostic information. But if you have an operable tumor, and if you have, say, a BRAF mutated patients, will you not operate the patient? Anybody would like to answer?
Of course, we'll operate the patient because it's an operable tumor.
That's fantastic. So the question is that then how do this information change your surgical management?
Because this information do not change my surgical management. That's why no molecular test is mandated before operation, because it's an operable tumor.
Okay, all right. Very good. Let's look at these statements one by one. So the patients need MMR, MSI, KRAS, NRAS, BRAF. I will disagree with that. Actually, you don't need this information. If the tumor is operable, you can make the decision about the operation and take the tumor out. But I would agree that the MMR will be helpful to some extent before and after. But again, it is not really required. B. So the A is false. B. RAS BRAF mutations do not confer poor prognosis in early stage CRC. Now, RAS BRAF, their information is actually more relevant in stage 4 or in advanced cases. Whatever so far the series suggests that if you're treating with an early stage cancer, then actually they do not make much difference. So I'll say that B is correct. Okay. C. Patient need only MMR and MSI result before operation. Now, if you think this is true, and if I tell you the patient said the patient has got a deficient MMR, will you not operate?
We will operate.
We'll operate.
These statements are, I'm sorry, I'm interrupting, but these statements are highly valuable in case of stage 2 or 3 cancer, where there is a question of neoadjuvant therapy, isn't it?
I've said that there is no indication of neoadjuvant therapy in the
Yes,
question.
but that's why these statements are not are not important in case of this patient, because this tumor is operable right now.
Okay, yes, I would agree. So the C is also false, that actually, again, you do not need the MMR or MSI result before the operation. Okay, now the D, the MMR and MSI test helpful after operation when adjuvant therapy is considered. Anybody wants to answer that question?
D is true.
D is true. Absolutely. Absolutely. Because we talked about that the patients who are deficient MMR, it is tied to the prognosis and as well as who can benefit or not benefit from the adjuvant therapy. And even in stage 3, we know that there are two options that you can give single agent fluoropyrimidine or you can give oxaliplatin and the fluoropyrimidine. The patients who are deficient MMR, single agent fluoropyrimidine treatment will not offer any extra benefit. So that information is helpful, but only when you are considering the adjuvant treatment. So E, which seems like by all probability a really stupid statement, is actually the most practical information here, that if you have an operable tumor, then actually you go and take it out. Now, whether you want to do all these tests or not, but they will not influence your surgical decision. That's what I'm trying to say, okay? Would anybody disagree with me?
Sir, I have a query,
Yes,
sir.
of
Patient need only
Yeah.
MMR before operation, sir. Sir, if there is MLH1 or MSS2 mutation, which is colon predominant, can we determine the extent of resection? Because chance of metacoronal lesion, you already show me the slides. So, sir,
That's actually a very good standpoint. And actually one of the question will cover that. But yes, I agree with you that. But one thing that I haven't asked, if the patient has any Lynch syndrome associated cancer in the family, then actually yes, then you will need to test the patient for the Lynch to confirm whether the patient has got Lynch or not, because that will change your surgical approach, because you may need to offer the patient the option of pancolectomy instead of a limited resection. So the C is kind of partially correct. However, I've not given any information in the question that the patient, I've not given any age and I've not given any family history. But you could argue that you can swing your arguments in both ways when it comes to the C. Okay, I take your point.
Sir,
So
আরেকটা স্যার বি স্যার স্যার আই মাইট বি রং স্যার আমি স্যার যেটা দেখেছি স্যার র্যাস বি র্যাপ যদি মিউটেশন থাকে যেটা পড়েছি চান্স অফ ডিস্টেন্ট মেটাস্টেসিস ইজ মোর চান্স অফ লোকাল রিকারেন্স ইজ মোর ইভেন র্যাস মিউটেশন ইজ অ্যাসোসিয়েটেড উইথ টিউমার বার্ডিং তাহলে স্যার আমরা তো আর্লি স্টেজ কোলোরেক্টাল ক্যান্সার ওকে স্যার কিন্তু স্যার এটা তো প্রোগনোসিস কি ক্যারি করে না স্যার যেখানে লোকাল রিকারেন্সের চান্স বেশি থাকবে পরবর্তীতে বা ডিস্টেন্ট মেটাস্টেসিসের চান্স বেশি থাকবে স্যার
I agree, but most of the data is actually from stage 4, and there is limited data because in the limited stage or stage 1 to 3, outside research, we don't normally do the RAS-BRAF test in the Western world. So the data is limited. So yes, there is common sense approach that BRAF mutated patients or RAS mutated patients will have a worse prognosis. But again, as I've said, that with the limited data, we do not know whether actually they confer poor prognosis in early stage. We do not have the established data.
So thank you, sir.
Is
So
true or
it's more kind of, you could say, a concern or more like an intuitive conclusion that if they're poor prognostic in stage 4, then they should be poor prognostic in earlier stages as well. But as I've said, we do not have the concrete data yet.
Sir, it is recommended that all colorectal patients should undergo MMR, MSI, or genetic testing for all patients, all colorectal cancers, either regardless of their have a family history or Lynch or sporadic. It is recommended now that all patients should go molecular testing.
Okay, so it depends on, it is more kind of what you call a public health kind of approach. So like in UK, all patients will have the MMR test on their biopsy before the operation. And the reason because that the UK government wants to diagnose all the Lynch patients and the carriers. However, it is not mandated in every country or in every health system. So if Bangladesh or if your patient as an individual can afford the test, then actually it's fantastic. But we are talking about whether this information will affect your surgical decision making. That is what the point is here. So what I'm trying to say that even if you did get a patient who's deficient MMR, would that stop you from operating the patient? You could say that, yes, I would offer the possibility of a pancolectomy, that you can say, but it doesn't still take away the fact that the patient is operable and the surgery should happen. We'll come to the lynch in a moment again in another question. Okay. Now, this is a second question that patient has got a locally advanced colon cancer. Okay. And if you are someone who favors neoadjuvant chemotherapy, if you're someone who is convinced by the Foxtrot trial, then you might be considering neoadjuvant chemotherapy. And again, I would like to again go through these statements starting with A. Would anybody agree or disagree with the first statement that a panel of MMR, MSI, KRAS, NRAS, BRAF is required before neoadjuvant chemotherapy?
False.
Anybody for okay, false. Okay, anybody for true?
I think it's true because it's a locally advanced cancer. It's already a stage 4 cancer, and the patient obviously will need MMR MSI because if the patient is, we have already discussed that if there is deficient MMR, then the patient will respond 4 to 5-fluorouracil therapy.
So this is a locally advanced tumor, but this is non-metastatic.
স্যার
And
এখানে এমএমআর এমএসআই স্যার করা যাবে স্যার বিকজ নিওঅ্যাডজুভেন্ট immunotherapy could be option স্যার as you already shown KRAS NRAS স্যার BRAF primarily আমরা করব না স্যার এটা মেটাস্টেসিস হলে করতে পারি
okay. All right. So we heard about the A and B. What about C and D? Anybody think C true? At least one of them are true and one of them is false, isn't it? And that's at least is clear from the structure of these statements.
স্যার নিওঅ্যাডজুভেন্ট কেমোথেরাপি
The C is
প্রফিশিয়েন্ট
true, sir.
এমএমআর যদি হয় should not be offered এটা should be offered এটা false স্যার
So the C is
T4B
false.
হয় হ্যাঁ জি স্যার
Okay, what about D?
He is stage dependent, sir. In case of stage 2, right-sided colon cancer, we can avoid
You've got a T4N2 tumor radiologically, clinically. So this is a stage 3 tumor.
stage 2 tumor.
True, sir.
The should not. This is false. So
So D
D.
is false.
It should be false. So immunotherapy can be considered in that case.
Okay, well, that's another interesting thought. Okay, what about E? Anybody wants to do an
স্যার
extended panel
মেটাস্টেটিক
biomarkers?
কোলোরেক্টাল ক্যান্সার না হলে স্যার HER2 P3 এটা তো প্রথমেই আমরা করব না
Okay, very good.
মাল্টি চ্যানেল প্যানেল টেস্টিং করা যেতে পারে কিন্তু স্যার খুব বেশি বেনিফিট হবে না
Very good. Okay, so let's go by one again. So the first thing is, do we need a large panel of MMR, MSI, KRAS, Anderson, BRAF? No, the answer is no. So it is false because we only need MMR to decide the benefit or to predict the benefit of neoadjuvant chemotherapy. So you don't need the full panel. Now, B says the molecular information has no value. It's not true. We already learned that the MMR information is helpful to understand the benefit of chemotherapy, isn't it? So the B B is also false. C, neoadjuvant chemotherapy should not be offered in proficient MMR, and the D is should not be offered in deficient MMR. So one statement is correct and one is wrong, and the answer is actually C is wrong because neoadjuvant chemotherapy has actually got a chance of downstaging in proficient MMR, and that's the information we learned from the Foxtrot trial. So from the Foxtrot trial, what it found out that if the patient is deficient MMR or MSI high, then the standard chemotherapy has got almost no chance or very little chance of downstaging in the deficient MMR. So what it means that if you want to consider neoadjuvant chemotherapy, now let's make it very clear. Foxtrot is a controversial trial in a sense that not everybody has accepted the recommendation from it. But if you are someone who truly believes in the neoadjuvant chemotherapy in locally advanced colon cancer, and if you want to give neoadjuvant chemotherapy, then please make sure that the patient is MMR proficient. Okay, that's what you need to keep in mind. And if it's a deficient MMR, then neoadjuvant chemotherapy has got no role. You either need to go for the surgery straight away, or you can discuss the option of immunotherapy with the patient. Okay. The final statement, the patient will need an extended panel of biomarkers. Again, this is wrong. Until and unless the patient has developed stage 4 disease, there is no role of these additional markers.
Sir, would
Okay.
you please repeat the statement C?
Okay. So in the Foxtrot trial, which looked at thousands of patients, and what they had neoadjuvant chemotherapy followed by surgery and followed by adjuvant treatment, which was compared against the standard treatment, which is surgery followed by adjuvant treatment. Okay. And what this trial has demonstrated that actually it failed to prove that the neoadjuvant chemotherapy improved the survival. However, what it did prove beyond any doubt is that the neoadjuvant chemotherapy is only helpful in proficient MMR patients, okay, not in the deficient MMR patients. Is that clear now?
Yeah.
So if you want, what I'm trying to say that if you want to consider neoadjuvant chemotherapy in a locally advanced but non-metastatic bowel cancer, then you can only consider it in proficient MMR patients, not in the deficient MMR patients.
Then, sir, why C is incorrect?
C is not correct. C is false, because you can offer neoadjuvant chemotherapy in proficient MMR patients. C is false.
Yes, sir, I got it.
Okay. All right. So next question. In a locally advanced rectal cancer, where you are considering total neoadjuvant therapy, following statements are true. So again, starting with the first statement, anybody wants to have a go? Anybody thinks it's true?
স্যার এখানেও শুধু এমএমআর এমএসআই আমরা করব, কেরাস এনরাস বিরাপ প্রথমেই করব না স্যার।
So KRAS and
It's a false
SBRAF
statement.
protein, right? So this is a false statement. Okay, anybody want to disagree with that?
I think it is true.
Okay. So if you have, say, a RAS mutated or BRAF mutated patient, would that change your TNT approach?
No, sir.
Okay, we'll come to that again. So the next statement, molecular information has no value in assessing the benefit of both neoadjuvant radiotherapy and chemotherapy. Anybody for true?
False.
Why false?
False. স্যার কিছু রেডিওথেরাপির স্যার মার্কার আমরা জানি স্যার, যেমন SMAD4 যদি থাকে বা P53 যদি থাকে মিউটেশন, তাহলে রেডিওথেরাপি রেসপন্সিভনেস কমে যায়, যদি রেডিও রেজিস্ট্যান্ট হয়। ইভেন স্যার আমরা FGXR জিন বা LYM LIM31 এটাও যদি হয় রেডিও রেজিস্ট্যান্স কমে যায়, এটা ফলস স্যার এই কারণে স্যার।
Okay. So actually, I was more
Marker.
focusing on the molecular information that you talked about, the MMR, KRAS, NRAS, BRAF. Does any of this has got any value in predicting the benefit of the neoadjuvant radiotherapy or chemotherapy?
Yes.
Can you explain further? There's one thing we should have learned by now, that in the deficient MMR patients, the chemotherapy doesn't work very well.
স্যার নিওড্রিভেন ইমিউনোথেরাপি আমরা দিতে পারি সেই ক্ষেত্রে স্যার।
Okay, I think that's the last option. We'll come to that. What about the B? Is it true or false, this statement?
Sir, true, sir.
True.
No, it's false. Has value.
No.
Has no value. So if the patient has got a deficient MMR, would the neoadjuvant chemotherapy work?
No, in case of deficient MMR, we won't offer chemotherapy. That's why it
So-
has got value.
Neoadjuvant
so-
immunotherapy, then we can offer, sir. If deficient MMR, sir.
we just need to get the answer right about whether this is quite a blanket statement, isn't it? The molecular information has no value in assessing the benefit of both neoadjuvant radiotherapy and chemotherapy. The answer is false, because as you've said, that there are some radiotherapy sensitivity markers, but again, the most important practical marker, the tests that you mentioned are not available on a day-to-day practice. However, MMR is available. And if the patient is MMR deficient, then they cannot have the chemoradiotherapy. They can only have the radiotherapy. And also, they cannot have the chemotherapy part of the TNT. So the TNT approach doesn't work in this group of people. Okay, so the B is false. Now the next statement, C, neoadjuvant chemotherapy will have no benefit in deficient MMR or MSI high. I think we kind of answered that already, haven't we?
True, it's a true statement.
So it's true. D, neoadjuvant chemoradiotherapy can be still offered without chemotherapy in deficient MMR or MSI high patients. What do you think about that?
True.
True. Okay, so this is still actually the standard of practice, that whether a patient is proficient MMR or deficient MMR, but if you're managing a locally advanced rectal cancer with CRM involved and all of those, then you still need to downstage. Okay, so you can still use the chemoradiotherapy as the treatment, but without the chemotherapy. Okay, so what I'm trying to say, that in the TNT patients, if they're deficient MMR, then TNT approach is unfortunately not going to work for them. Okay, and the final statement, immunotherapy without surgery is the standard of care in deficient MMR and MSI high patients.
Actually, false.
Is it true or false?
False.
Why false?
Surgery is the first line treatment.
Surgery is the first line, exactly.
Okay. So this is actually probably the most contentious issue at the moment in the locally advanced rectal cancer who are deficient MMR, because in the SARSEC paper, as well as the NICHE and NICHE-2 trials, both has demonstrated that a deficient MMR patient has got an incredible response rate to immunotherapy. Okay, but remember, those are phase 1 and phase 2 trials at their best. Okay, the SARSEC paper is only about 12 patients. Now, can you apply a phase 1, phase 2 trial data and change your practice completely? The answer by common sense says that no, it can't. However,
Niche trial is about the colon cancer, I think so.
yes, so the SARSEC paper is on the rectal cancer, locally advanced rectal cancer. The NICHE is on the colon cancer. Okay, but the both has demonstrated one fundamental outcome, that the deficient MMR patients can respond incredibly well. The vast majority can achieve a complete response from the immunotherapy alone. And this has created a big debate, because to do a phase 3 trial and wait for the results, it may take 10 years, a decade. Can you wait for 10 years? And while we already know that the patient can respond brilliantly, incredibly well to immunotherapy without the need of a surgery. However, it is not the standard of care yet. There's no guidelines in the world that has suggested that the immunotherapy should be the standard of care. So the surgery still remains the standard of care when possible. Okay, so this treatment is unfortunately false, even though it is inherently probably going in the right direction. Okay, so you've got your next question. You've got a young person who comes to you with a diagnosis of an operable colon cancer. However, the patient's mom had endometrial cancer at the age of 40. Patient's brother had a glioma at the age of 35. So these are alerting you the possibility of the Lynch syndrome in the patient. Okay, and now let's look at these statements. Pancolectomy should be offered based on family history alone. Does anybody agree with that?
False, sir.
Okay, why false?
False.
Why
স্যার
false?
জার্মলাইন টেস্টিং ফ্যামিলিতে যদি পজিটিভ থাকে, পেশেন্টেরও জার্মলাইন টেস্টিং করে নিতে হবে এবং দেখতে হবে যে সেটা কোলন প্রিডমিনেন্ট কিনা, MLH1 MSH2 কিনা। তারপরেও পেশেন্টের সাথে আলোচনা করতে হবে রিস্ক বেনিফিট, তারপরে স্যার টোটাল করে দিতে হবে।
Good. Anybody disagree with that? Anybody think they should do a pancolectomy just based on the family history alone? Nobody. Good. Fantastic. So yes, that's the right answer. That is a false statement. Let's not forget that even though Lynch syndrome is autosomal dominant, but you need both the alleles to be deactivated for the disease to manifest. And what it means that it can actually, the patients who's got a Lynch parent, they still have 50% chance of not to be a Lynch syndrome. Okay, so to do a pancolectomy without confirming is no less than a crime. Okay. So the next statement, investigations must be done to confirm the presence or absence of Lynch syndrome before surgical resection of primary. Anybody agree or disagree with that?
True, actually.
True, okay. Anybody who disagree? Okay. So this is actually also tied to the fifth statement, where when you talk about the pancolectomy or a more extensive surgical resection of the whole colon, can it be done as a staged procedure? Can that be an option for the patient? Isn't it? Because if that's an option for the patient, or if the patient is right now unwilling to have a pancolectomy, even though they're Lynch positive, then actually you don't need the confirmation of the Lynch syndrome. But I would agree that actually ideally when there is enough suspicion, the patient is young, there are at least 2 Lynch associated cancer in the family, I would like to confirm that the patient has got Lynch syndrome or not before planning any surgery. Okay. Third statement, confirmation of Lynch syndrome is not obligatory before surgical resection. True or false?
False.
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 Okay. Would anybody disagree?
So B true হলে তো C false হবে।
B true hole, C false. That's the kind of deduction, I guess. Now, at the end of the day, again, patients does anybody know how the Lynch is confirmed? What does the confirmatory test involves, or how long does
Germline
genetic testing.
germline testing? And it can take sometimes even weeks to months before the result will come back, isn't it?
And even not positive, even not be positive.
Okay, so the question is that would you as a surgeon, as a patient, willingly wait for months to wait for the result to be confirmed and then do the operation? Okay, again, as I've said, that these are tied with the very fifth statement. We'll come to that in a moment. Okay, so the fourth statement is total colectomy should be only offered as an option after confirmation of Lynch syndrome. True or false?
True.
True.
Okay, so that looks like a very resounding true from everybody. And I would agree, yes, only after confirmation of the Lynch syndrome, total colectomy should be offered, but remember, as an option, it's not mandatory. And that comes to the fifth statement, which kind of ties with the second and third one, that prophylactic total colectomy or pancolectomy can be done as staged procedure later after resection of the primary tumor.
False.
True.
It's true.
Actually, true.
True answer.
Okay. So who in favor of false? Can you explain the argument why it's false?
Sir, staged procedure. I disagree with the staged procedure.
So it means that you take the primary out now, okay? And then you offer the patient later on about the option of pancolectomy. So that's what is called a staged procedure. Sorry, have I lost you? I can't hear anything.
Bolo?
Are the students still with me? Are the trainees still with me? I'm sorry.
Yes, I can hear.
Sir.
Yeah.
Yes,
Okay.
we are.
So I think I heard most were answering true. for the fifth statement, the prophylactic pancolectomy can be done as a staged procedure later after the resection of the primary tumor. Okay, and I would say this is true because not every patient will be prepared for a pancolectomy straight away. Okay, and in that case, you can still do the resection of the primary tumor. Okay, you can wait for the Lynch to be confirmed, and only when it's confirmed that the patient can come back to the surgeons to have a discussion about the merits of the pancolectomy. And now, if we use that information in assessing the statement 2 and statement 3, then actually our previous answers can be different, isn't it? Because it means that we do not need a confirmation of Lynch syndrome before the resection of the primary. Okay?
Right.
And the same thing also can be applied in the statement 2, that you could say that we can set the investigations in process. We can do the investigations side by side about confirming about the Lynch syndrome. But if the patient is prepared for the primary tumor resection, then actually that can go ahead. Okay, so actually in UK, most patients, they are actually not prepared to go for a pancolectomy and live with a permanent stoma at such an early stage. They need time to think about it, and it's a quality of life question. A lot of things are involved. So taking the whole colon out for a young patient and then they'll have to live with it for the rest of their life is actually not an easy decision. Okay. Now, once again, this highlights the difficulties and the challenges that as a surgeon that you will face and you will deal. And as you can see, that right answer is not always the right answer as it seems, or the wrong answer can be the right answer as well. So that concludes all my questions. And I just want to summarize that of all the molecular tests that we do, that we hear, that we learn, actually, as a surgeon, the most important information that you need to know very well is the role and application of MMR in your patients. Okay, so whether it's an operable tumor, whether you're looking at downstaging with neoadjuvant treatment, or whether you're looking at a nasty rectal cancer that you're thinking TNT, the only information that really shapes your plan is the MMR. And the other information, they're as helpful as they can be, but none of those changes your mind about your surgical treatment as the MMR does. Okay, so hopefully I'm able to give that message, and this is where I will conclude. Thank you very much for listening.
Thank you, Dr. Jayed, for your brilliant presentations and the interactions. Really, I think যে চারটা সিনারিও নিয়ে আলোচনা করা হলো, that covers almost মানে very bulk part of this colorectal cancer. Really brilliant. Great. So এখন দেখি একটু কোশ্চেন আনসার সেশন আমাদের স্টুডেন্টদের থেকে।
Sir, I have one question to Jahid sir.
Yes, sure.
Sir, so will you please share the slides again?
Okay.
The third scenario.
Third scenario. Okay, just give me 1 second. Has it come up?
It's coming.
Okay.
Third one, right.
Yeah. So, sir, the last statement.
Yes.
Immunotherapy without surgery is the standard of care.
Sir, no, sir. Yes. Immunotherapy without is the standard of care in deficit MMR or MSI high locally advanced. So, if we consider the patient for the WW policy, so then it might be the true answer.
I'm sorry, I didn't understand the DWW policy.
The watch and wait policy.
Okay.
So in
but
that
in
case,
the watch and wait, there is no intervention. If you're giving immunotherapy, that's an intervention. Then it's not watch and wait.
Okay. So we can't do watch and wait in these cases.
It's a locally advanced tumor. It's a nasty tumor. It's going to metastasize very soon. So you have to manage it now, unless the patient is unfit for surgery. That's different. Or unfit for the neoadjuvant treatment. That's different. But
Okay.
watch and wait is not an option in locally advanced rectal cancer.
So, sir, we are offering immunotherapy after TNT?
No. No. If the TNT has been successful and either the patient has achieved a complete response or you have taken the residual tumor out, then there is no further adjuvant treatment is recommended in TNT approach because you're doing everything upfront. Okay.
So when you are offering, sir, immunotherapy in deficit MMR patients,
Okay. So this
so
is the
you are
emerging.
giving CRT to all the deficit MMR patients, right, sir?
Okay. So we are let's differentiate. If you're talking about a stage 4 tumor, which has
Okay.
got deficient MMR, then your best treatment is immunotherapy. Is that clear?
Yes.
Okay. Now you're talking about a non-metastatic setting. So basically, we're talking about a potentially operable tumor or an downstageable tumor like in TNT. Okay. There is a huge debate going on in this area is whether we should be waiting for a phase 3 trial. Okay. In the phase 3 trial, to do that, you will need at least 2 to 3 years of recruitment, another 2 to 3 years of treating them, and then wait for another few years. So it can take up to 10 years before you get the data of the phase 3 trial. Okay. Now,
Yes.
what people are arguing, do we need to wait for a phase 3 trial in the DMMR patients while we already know that their major pathological response rate is actually 90% or higher with the immunotherapy? And most of them do not need surgery. Their response is so good that they don't need surgery. And that has become the hot debate now. And the answer is nobody has agreed. No guidelines has yet to be changed to say that immunotherapy is the standard of care. So the catch in this statement is the standard of care. What is the current standard of care? Okay. And the current standard of care is still neoadjuvant therapy followed by surgery in the locally advanced rectal cancer. Okay. But the reason I've put that statement up, that maybe at some point in the future, this statement will become the truth. Okay. Maybe not in my lifetime or maybe in your lifetime, you will see that that the guidelines maybe will, as more data suggests. Let's talk about one thing. Oncology is actually quite different than the rest of the specialties. Do you know why? Because the oncology trials are the most rigorous and most robust trials of all the specialties. Okay. With no disrespect, in other specialties, you can take case control studies, cohort studies, and they can be used as an evidence to change practice. However, in oncology, to change practice is very difficult to change practice without a very successful phase 3 trial. Okay. Now, remember, as I've said, your DMMR patients in stage 4 are only 4%. In stage 2, stage 3, you've got 10, 15% to 10 to 20%. Now think about to do a trial, and it's a common cancer, okay? And you know the statistic in common cancer, you need thousands of patients to have the statistical power. Now think about in a common cancer, if you have to do a phase 3 trial and knowing that this is actually a small proportion of the major bulk, you will need years to actually run a trial and get an answer. And that's what is now the oncology community asking, that we have created this very high barrier that, okay, we'll not take anything other than a phase 3 trial to change our practice. But actually, we now understand that bowel cancer is not a bowel cancer. It's got a number of different molecularly and genetically different cancer, just like we see in breast cancer, in other cancer. So can we use still our previous approach that we must have a phase 3 trial to change the practice? And this is where the debate is going on, because we are not treating a bowel cancer or any other cancer. We look at the molecular profile and we manage accordingly. Okay. So this is the current approach. And that's where the people who are not in favor of phase 3 trial this is their argument, that we are not treating bowel cancer. We are talking about a very specific molecular subtype. Why do we need a phase 3 trial to change our practice when there's already quite overwhelming data from the Sarsek paper, from the niche and the niche 2 trial they're suggesting that more than 90% people can actually have a major pathological response. Okay, so the bottom line is that it is still not the standard of care, but the reason I've put that statement so that you are aware that this is coming, and maybe at some point in future, this might become the standard of care.
Okay.
Sir, I have one question. Sir, please clarify about C and D statement.
Okay, so to understand the C and D statement, we have to go back to the Foxtrot trial. So the Foxtrot trial looked at the number one, the feasibility, and number two, the clinical benefit of neoadjuvant chemotherapy in locally advanced but non-metastatic colon cancer. And the eligibility criteria included at least T3 tumor or NET and node positive, okay? However, these are not obstructed, perforated, or there isn't any T4B tumor. So basically a tumor that is operable, but it is locally advanced, okay? So the trial was designed in a way that one group of patients had standard treatment, and the standard treatment was surgery, and then followed by adjuvant therapy, depending on the histology, okay, which is what we do on a normal day today. And this other approach, or the trial approach, was that they will have 6 weeks of neoadjuvant chemotherapy, followed by surgery, and the rest of the chemotherapy will be given as an adjuvant setting, okay? So the trial was successful in many ways because it has shown that actually this is feasible. The perioperative mortality and morbidity was actually no worse. To some extent, it was better. Okay, so it has concluded that it is feasible and it's clinically safe. And there is also an improved downstaging in the pathological resection after neoadjuvant treatment. However, the overall hazard ratio which they wanted to achieve, they couldn't achieve it. And the reason was because of the deficient MMR patients, and this was done as a post hoc analysis. That means that this was done after the trial, not before, okay? So the statistics did not take into account of the possibility of the deficient MMR patients and separated them. And what is shown, the patients who are deficient MMR, they had no downstaging from the neoadjuvant chemotherapy. And the only downstaging that happened was in the proficient MMR patients. Let's hear it again. Downstaging did not happen in the deficient MMR patients. It only happened in the proficient MMR patients. And now use this information in C and D. So the C says neoadjuvant chemotherapy will have no benefit in dMMR or MSI high patient. It is true.
True.
I just said that neoadjuvant chemotherapy doesn't downstage from the Foxtrot trial, we know. And this is not only Foxtrot trial. If you're treating upper GI patients, you also know from the FLOT trial and also the MAGIC data that the deficient MMR patients, they don't respond to the perioperative chemotherapy, okay? So this is not just colon cancer. This is other cancers which are deficient MMR. Now, let's look at the fourth D, statement D. Neoadjuvant chemoradiotherapy can be still offered without chemotherapy in deficient MMR. And that's true because the radiotherapy is kind of independent about the MMR status, while chemotherapy is. So even if we don't give the neoadjuvant chemotherapy of the TNT, we can still give the CRT. And that's still valid, and that will be still a standard thing to do. So that's true. Does it make sense now?
Sir, in chemoradiotherapy, we also use the chemotherapy also.
You can avoid the chemotherapy, you can, but the radiotherapy is still a valid option.
So term should be only radiotherapy.
Yeah.
Neoadjuvant radiotherapy or.
Okay, now you ask you the question, what is the role of chemotherapy in the chemoradiotherapy? Does it downstage? Is it given to
Sensitizer,
downstage?
sir.
No.
It's radiosensitizer.
Yes.
Okay.
Yes,
And that's why.
Yeah.
And that's
Sir,
why
question
you can give the
first
CRT.
statement.
Sorry.
The first statement, third scenario, the panel of Elmer KRS address BRAF is required before TNT. Sir, third scenario, the first statement.
Okay.
Sir, is it all the time? Because if we consider cetuximab on TNT protocol, shouldn't we do the BRAF Yes, some center practices. I
Okay,
have seen many
so
patients got cetuximab on TNT protocol. So
I've never heard of giving an EGFR antibody in the TNT protocol. There is no accepted protocol like that in the Western world.
okay, sir. Then if there may be tumor change in tumor biology after TNT. So considering the future planning second line chemotherapy, so should we consider the KRAS, NRAS, BRAF prior to the TNT?
Okay, so let's clarify that issue. I think it's very important. So from the Foxtrot trial and the Prodige trial, which has looked at neoadjuvant treatment, and they have looked at as one of their arms the addition of the EGFR targeted antibody, it has become very clear that in early stage cancer, the EGFR targeted antibody has got no benefit. Okay. Let's be very clear that there's no TNT protocol that we use in the Western world where we'll be using an EGFR targeted antibody with the chemotherapy. Okay. So which means that we don't need the RAS BRAF information. We don't need the RAS BRAF information. If you're only doing TNT, the only information you need is the MMR, because you need to know whether the chemotherapy will have any benefit in downstaging the tumor. You can always do the KRAS and NRAS and BRAF after the operation of the tumor specimen in case the patient develops metastatic disease. This doesn't have patient who doesn't have a metastatic disease, you don't need to do these molecular tests.
জাহিদ আমি একটু ওকে
So
ইন্টারফেয়ার
what are the roles of
জাহিদ
KRAS in this? Here.
ওর যে কোয়েশ্চেনটা
What is the
ওই এক সেকেন্ড ওই লোপার যে কোয়েশ্চেনটা ছিল প্রবাবলি ও কনফিউজ করছে যে নিয়ার জীবন ট্রিটমেন্ট টিএনটি দেওয়ার পরে পরে যদি রিকোয়ারমেন্ট হয় ফর দি সেকেন্ড লাইন অর টার্গেটেড থেরাপি দেন দি মলিকুলার স্ট্যাটাস মে বি চেঞ্জ দ্যান দি ইনিশিয়াল ওয়ান সো দ্যাট সে রিকোয়ারমেন্ট অফ দি এনজিএস সে বলতে চাচ্ছে যে এনজিএসটাতে আগে করে রাখলে সব র্যাস প্রোফাইলে হাতে থাকলো তখন সে সেকেন্ড লাইনে বা টার্গেটেড থেরাপি দেওয়ার জন্য তার সুবিধা হবে কিন্তু এই স্টেটমেন্ট তো তা নাই স্টেটমেন্ট হচ্ছে ফর দি টিএনটির জন্য তো এটা দরকার নাই
No. Now, just to clarify, I understand a system works differently in different countries. So like in UK, so if we need molecular test, we can do it later on the specimen. I understand that's not easy in Bangladesh, because if you're seeing a patient and if the patient is not coming back, then you're losing the opportunity to do this test, or I mean আমাদের যেরকম একটা direct communication আছে pathologistদের সাথে সেরকম হয়তো আমি জানি না, so it might be logistical reason I can understand, but as far as the TNT is concerned, we don't need the RAS BRAF information.
জাহিদ আরেকটা জিনিস আমি একটু শেয়ার করতে চাচ্ছিলাম
জি
সেটা হচ্ছে যে ওই যে স্টুডেন্টটা জিজ্ঞেস করছে ইমিউনোথেরাপি উইদাউট সার্জারি ইজ স্ট্যান্ডার্ড অফ কেয়ার ও প্রবাবলি ওই যে এনসিসিএন এ যে গাইডলাইনটা আসছে যে লোকালি অ্যাডভান্স রেকটাল ক্যান্সার উইদাউট মেটাস্টেটিক ডিজিজ সো দ্যাট ডিএমএমআর পেশেন্ট ইমিউন চেকপয়েন্ট ইনহিবিটর তাকে দেওয়া যেতে পারে এবং সেখানে যদি সে সিসিআর হয়ে যায় দিস পেশেন্ট গো টু দি ডাব্লিউডাব্লিউ পলিসি অ্যান্ড ফর দি সার্ভাইলেন্স সো আমার ধারণা ও এইটা বলতে যাচ্ছিল বাট ডাব্লিউডাব্লিউ পলিসি ইজ নট দি স্ট্যান্ডার্ড অফ কেয়ার
And I agree. So the NCCN, so আপনি জানেন যে it operates in a slightly different way than the European guidelines.
Yes.
যে NCCN, anything that has shown some benefit, NCCN will include in their guidelines. Which, however, that's not how the European guidelines work. So from my guideline,
Okay.
I would disagree, and I would say that yes, it's an option. It certainly is an option, but it is not the standard of care yet.
Yes, not the standard of care, right.
But as I've said, I've put this statement deliberately because this is a very controversial statement, and at some point in future, I believe this will be a true statement.
Okay.
Actually, what are the role of KRAS and NRAS, sir? Here.
So the KRAS and NRAS, they indicate poor prognosis when they're mutated in the colon cancer, and they have got proven prognostic information, predictive information stage 4. But the difficulty is that we are extrapolating that information, and we think we can apply to an early stage cancer. But the difficulty is that in the vast majority of the translational studies that were done in the early stage cancer, or the trials that were done, they actually did not look at the RAS BRAF information in early stage cancers. So their sensitivity in regards to prognosis is uncertain in early stage cancer. And that's why I'm saying that you do not need this information when you're managing an operable cancer.
Okay. Okay, thank you. Any more questions? ডক্টর আসান কোনো কোশ্চেন আছে চ্যাট বক্সে যেগুলো অ্যাড্রেস করা হয়নি?
স্যার না,
ডাইরেক্ট কোনো স্টুডেন্টের ডাইরেক্ট কোনো কোয়েশ্চেন আছে কিনা? কারণ জাহেদকে পাইছো মানে কি, জাহেদ কিন্তু তার অনেক ভালো নলেজ এই বিষয়ে, বুঝছো তো? লেকচারে যে দেখছো, আউটস্ট্যান্ডিং লেকচার।
আউটস্ট্যান্ডিং, রিয়েলি আউটস্ট্যান্ডিং।
সো কোনো স্টুডেন্টের কোনো কোয়েশ্চেন আছে কিনা? কারণ মলিকুলারে তো অনেক
যেগুলো কোশ্চেন
কনফিউশন
ছিল
থাকে।
অলরেডি ডিসকাস হয়েছে, প্রফিশিয়েন্ট এমএমআর, ডিফিশিয়েন্ট এমএমআর, কেরাস এনরেস এর রোল, এগুলো অলরেডি
স্যার আমার একটা কোয়েরি ছিল স্যার।
পরিচয় বলো।
স্যার প্রশ্নটা হচ্ছে স্যার এডিনোমা কার্সিনোমা
কল্যাণ
স্যার, কল্যাণ স্যার।
আচ্ছা, মানে তুমি কোলোরেক্টালের বলবা তো, কোলোরেক্টালের স্টুডেন্ট?
জি স্যার, স্যার আমি ফেস বি রেসিডেন্ট কোলোরেক্টাল সার্জারি ফ্রম বিএসএম স্যার। স্যার আমার কোশ্চেনটা হচ্ছে স্যার এডিনোমা কার্সিনোমা সিকোয়েন্স স্যার 85% ক্ষেত্রে স্যার ক্রোমোজোম ইনস্টেবিলিটি যেখানে ফলো হয় স্যার, এখানে ফার্স্টে স্যার এপিসিজি মিউটেশন ফলোড বাই কেরাস ফলোড বাই ডিসিসি এন্ড p53 স্যার। সো স্যার 85% ক্ষেত্রে যদি এটা ফলো হয়, পরবর্তীতে দেখা যায় ওভারঅল স্যার আমরা যদি মিউটেশন অ্যাসেসমেন্ট করি, দেখা যায় কেরাস স্যার 40% পাওয়া যায়। তাহলে স্যার নর্মাল তো সব অ্যাডিনোমা কার্সিনোমা সিকোয়েন্স এই পাথ এটা ফলো করছে, আলটিমেটলি স্যার টিউমারে 40% কেন পাওয়া যায় স্যার? It might be the stupid question, sir.
No, it's a very good question, and the truth is, I don't know the answer. The only way I can say that as the tumor changes, it probably goes through a mutational evolution. So it can acquire more mutations. It can lose some of its earlier mutations. It depends on when you are diagnosing the patient, isn't it? So even though the KRAS is changing from adenoma to carcinoma sequence, why we are not getting everybody KRAS mutated, isn't it? I don't know the answer, I'm afraid.
Okay then.
I have a question.
Yes, sure.
One thing we haven't discussed that reminds me, that's actually that we haven't talked much about the sporadic MMR mutation that if you look for the MMR deficient patients, in the vast majority is actually it comes back in sporadic, and more often this is in elderly patients, because remember as we grow older, the DNA mismatch repair system actually gradually becomes weaker and weaker, and that's why in old age we can get all kinds of cancer, not just colon cancer. Okay, just to keep in mind that the in an older patient is more likely to be sporadic. If it's a younger patient, it's more likely to be germline mutation. However, their management is same. The treatment doesn't differ whether it's sporadic or whether it's germline.
Okay, thank you. অনেক ডিসকাশন হলো আমাদের। এখন আমরা একটু ফ্যাকাল্টিদের থেকে একটু কমেন্ট নিব। তার আগে স্টুডেন্টদের জন্য একটা অ্যানাউন্সমেন্ট আছে। ডিয়ার স্টুডেন্টস, আমাদের আগামীকাল একটা স্পেশাল ক্লাস হবে, দ্যাট ইজ ইন অ্যাসোসিয়েশন উইথ দ্য সোসাইটি অফ দ্য মাইক্রোবায়োলজিস্ট অন অ্যান্টিবায়োগ্রাম। অ্যান্টিবায়োগ্রাম, সো এটা হবে আগামীকাল রাত্র 8টায়। সো ইউ উইল গেট দ্য জুম লিঙ্ক টুনাইট. Antibiogram is a very important topic for the surgical residents and the surgeon as well. Okay, you all are invited to join this webinar on antibiogram tomorrow at 8 p.m. Okay, so এখন আমরা একটু ফ্যাকাল্টি থেকে কমেন্ট নিই। আমাদের সঙ্গে ছিল হাসান, প্রফেসর হাসান, will you make any comment? আর প্রফেসর জামালকে দেখলাম। আচ্ছা, হাসানকে দেখতে পাচ্ছি। হাসান, ক্যান ইউ হিয়ার মি? ওকে, প্রফেসর শাহাদ হোসেন শেখ।
স্যার আমি তো টুকটাক দু একটা কথা বললামই এখন। কমেন্ট হচ্ছে যে জাহেদ সম্পর্কে আমার কমেন্ট হচ্ছে যে আমি যখন কোনো কিছু বুঝতে না পারি তখন জাহেদকে আমি মেসেজ পাঠাই, জাহেদ আবার সেটাকে ক্লিয়ারলি এই কয়েক ঘন্টার মধ্যে আমাকে রিপ্লাই করে। সো দ্যাট এইভাবে আমি ওর কাছ থেকে অনেক কিছু শিখি। আই হোপ যে আমার স্টুডেন্ট যে কোশ্চেনটা করছে ওই কোশ্চেনটা আমারও ছিল, আমি ওকে বলছি জাহেদকে জিজ্ঞেস করে আমাকে করুন, ও আনসার করবে। তো হোপফুলি জাহেদ এটাকে আনসার করবে ইন টাইম। পরে আবার স্টুডেন্টদেরকে আমি সেটা জানাবো। বাট ইটস এ ওয়ান্ডারফুল ক্লাস, এটা আমার কাছে এত পছন্দ হয়েছে যে মানে এটা ক্লিয়ার হওয়ার জন্য। ধরো মলিকুলার এই বিষয়গুলোতে একটু জটিলও আছে সার্জনদের জন্য, বাট স্টিল আমার কাছে মনে হয় যে অনেক কিছুই ক্লিয়ার হয়েছে। আমার কাছে, আমার নিজের কাছেও আমি অনেক কিছু ক্লিয়ার হয়েছে ওর এই লেকচার থেকে। সো জাহিদ, কংগ্রেচুলেশন ফর দ্য ওয়ান্ডারফুল লেকচার।
রিয়েলি রিয়েলি অ্যাপ্রিসিয়েট। জামাল, প্রফেসর জামাল আছে? নো। প্রফেসর মার্গোসন স্যার?
আমি তো একটা গবেট।
কেন স্যার? আপনার আপনার স্টুডেন্টস আপনার
You went so deep. You went so deep যে it is somewhat ইয়ে, কারণ এগুলি নিয়ে এখন আমি বেশি নাড়াচাড়া করি না, সেই জন্য একটা এনিওয়ে শেখার অনেক কিছুই আছে এর মধ্যে। তার মধ্যে একটা হচ্ছে যে এটা তো ঠিক যে দ্যার ইজ নো ইয়ে কি বলে হোয়াট ইউ কল, ডিসিশন গুলি আমাদের চেঞ্জ করতে হবে আস্তে আস্তে প্রত্যেকবারই, কোনো ইয়ে নাই এর মধ্যে। কিন্তু এখন এই যে ইয়েগুলি, যে জিনিসটা এখন মানে রুগীরা বলে না ক্যান্সারের জীবাণু পাওয়া যায় নাই, আমাদের ক্যান্সার সেলগুলি আমার কাছে মনে হয় যে ব্রেস্ট ক্যান্সারে যেটা বললাম, এতে বললাম এগুলি, যে এই ক্যান্সার সেলগুলি তাদের এত মিউটেশন হয়, ওরা ওই ব্যাকটেরিয়ার মতোই আচরণ করতে থাকে। They change their lifestyle, they change their mutation, they change their characteristics, everything, so that you don't get the tumor in the 1 year or 2 year after the treatment when it comes again, অথবা when it is there. একটা জায়গায় পড়ছিলাম যে সব বেয়াদব সেলগুলি জীবিত থাকে, wicked cells remain alive and they produce more wicked generations. সেজন্য ওই যে ছোটখাটো চেঞ্জ করে অনেক কিছু চেঞ্জ হয়ে যাচ্ছে, দে ডোন্ট রেসপন্ড টু এনিথিং এন্ড দে শো আস সামথিং তো সেই হিসাবে ওটা চিন্তা করলে এখন যেটা ভবিষ্যতের কথা চিন্তা করলে যেটা হয় যে দেয়ার উইল বি সো মেনি ভেরিয়েশনস যে ইট উইল বি ডিফিকাল্ট টু টেক এনি ডিসিশন এক্স্যাক্টলি কোনো সেজন্য ওই মানে কোনো ডিসিশনই একেবারে 100% শিওর এটা বলা যাবে না। You can take any decision which is correct. There is no absolute right or wrong in any decision. এটা আমাকে একজন বলছিল আমার মেয়ের চিকিৎসার সময়, there is no right or wrong in any decision. He is an oncologist. তাকে যখন অন্যান্য অঙ্কোলজিস্ট গিয়ে জানালাম, সে বললো যে there is no right or wrong in any absolute right or wrong in any decision. এটা সব ক্ষেত্রেই ইয়ে লাগবে। শুধু বলবো যে হ্যাঁ, ও যদি আরো কটা ক্লাস নেয়, জাহিদ স্যার যদি আরো কটা ক্লাস নেয় আমাদের, তাহলে ভালো হবে
শিওর
ভবিষ্যতে।
হ্যাঁ, উইল টেক ক্লাস স্যার ইনশাআল্লাহ।
ক্লাসটা একদিক থেকে খুবই হয়েছে যে স্টুডেন্টস দে পার্টিসিপেটেড, দ্যাট ওয়াজ দ্য কোশ্চেনগুলি দেখেন, কোশ্চেনগুলি কিন্তু থট প্রভোকিং,
কোশ্চেন এবং
রেসপন্সগুলি থট প্রভোকিং, যে আপনি দেওয়ার আগে চিন্তা করতে হবে। দ্যাট ইজ হাউ ইউ মেক ইউর লেকচার ইন্টারেক্টিভ। থ্যাংক ইউ জাহিদ।
really brilliant way of interacting with the students. The মানে teaching style is really excellent. আমি দেখি এখন একটু জাহিদের ফ্রেন্ডরা আছে কিনা। ডক্টর লিমা আছে? শাহিদা ছিল তো। আচ্ছা, however আর কোনো ফ্যাকাল্টি কোনো কিছু বলবেন? any comment from any faculty? ওকে, এখন লাস্টলি আমি জাহিদকে বলছি জাস্ট you tell something and just make comments about our webinar and advice to students. You are muted.
থ্যাংক ইউ যে আমাকে ইনভাইট করার জন্য। আই রিয়েলি এনজয় দিস সেশনস, এবং আমার জন্য এটা মানে ব্যক্তিগতভাবে আমি খুব পার্সোনাল, বিকজ মারগুপ স্যার আছেন, আপনি আছেন, আপনাদের সাথে আবার যে যোগাযোগ হচ্ছে, কথা হচ্ছে। ট্রেনি যারা আছে তাদের জন্য বলছে যে তারা দুজনই আমার সরাসরি টিচার। শাহাদাত স্যার আছেন, যার সাথে পরিচয় হয়েছে এই একাডেমিক অ্যাক্টিভিটিগুলোর মাধ্যমে। আমি খুবই এনজয় করি। ট্রেনিং সার্জনদের উদ্দেশ্যে যেটা বলবো সেটা হচ্ছে যে আজকে থেকে 15-20 বছর আগে যখন আমরা অনকোলজি ট্রেনি ছিলাম, মলিকুলার ইনফরমেশন সম্পর্কে আমরা কিছু জানতাম না। তখন ক্যান্সার ট্রিট হতো শুধুমাত্র কিমোথেরাপি দিয়ে। তারপর আমরা দেখলাম যে মলিকুলার ইনফরমেশনের যুগ শুরু হলো, যে ট্রিটমেন্টস আর স্ট্র্যাটিফাইড অ্যাকর্ডিং টু মলিকুলার ইনফরমেশন। তখনও সার্জনদের অতটা ছিল না যে তাদেরকে জানতেই হবে, বুঝতেই হবে, কারণ পুরো জিনিসটাই ছিল অনকোলজি লেভেলে বা সিস্টেমিক ট্রিটমেন্ট লেভেলে। কিন্তু আমরা এখন এমন একটা পর্যায়ে আসছি যে সবাইকেই আসলে জানতে হবে, যে সার্জনদেরও আসলে এখন আর রেহাই নাই। তাদেরও জানতে হবে যে কোথায় একটা মলিকুলার ইনফরমেশনের রোল আছে তার সার্জিক্যাল ডিসিশন মেকিং এর জন্য। সো উই আর মুভিং অ্যাওয়ে টু আ ডিফারেন্ট ইরা, যেখানে আওয়ার ওল্ড প্র্যাকটিস আর ওল্ড ওয়ে অফ ডুইং থিংস ইজ নট গোয়িং টু ওয়ার্ক এনিমোর। আই অ্যাপ্রিসিয়েট যে আমরা টেস্টগুলোর কথা বলি, এগুলোর অনেক খরচের ব্যাপার আছে। আমি হয়তো শিওর জানি না, কিন্তু 40-50 হাজার 60 হাজার আমি অনেক শুনি যে এক একটা টেস্ট করতে লাগে। সুতরাং অ্যাজ এ সার্জন আপনাদের তো চিন্তা করতে হবে যে আপনাদের রোগী এটা বহন করতে পারবে কিনা। সুতরাং যদি কোন টেস্ট করতে দেন, তাহলে আপনাকে চিন্তা করতে হবে যে কোন টেস্টটা আমাকে সবচেয়ে বেশি আমার জন্য বেনিফিশিয়াল হবে আমার সার্জিক্যাল ডিসিশনের জন্য, আর কোনটা আমার আপাতত দরকার নেই, যেটা রোগী পরেও করাতে পারবে যদি দরকার হয়। তাই এই প্র্যাকটিক্যাল অ্যাপ্রোচটা যদি থাকে তাহলে এটা রোগীদের জন্য ভালো হবে। আর আবারও বলবো যে অ্যাজ এ সার্জন, আনফর্চুনেটলি ইউ আর ইন আ জেনারেশন ওয়্যার ইউ উইল নিড টু নো অ্যাবাউট molecular information in cancers.
Yes.
Thank you.
Thank you. Thank you very much. And thank you all. Very good session. Really appreciate. One of the best session in our PGS Academia. Thank you, Jahid. We'll invite you again. As Professor Margub sir said, another 2 or 3 more lectures on the different. Definitely, I will invite you. So see you again. Till then, stay safe, stay blessed. Dekha hobe inshallah. Professor Shahadat, Margub sir, thank you very much. Assalamu
Thank
alaikum.
you.
Thank you, sir. Really, we enjoyed.
Really enjoyed.
আসসালামু আলাইকুম স্যার।
হাসান আছে নাকি? হাসানকে দেখছিলাম বারে বারে। ওকে ওকে, থ্যাংক ইউ অল। স্যার কাল একটু স্যার মানে আছে অ্যান্টিবায়োগ্রাম, ওইটার উপরে একটা বেশিটা 1 ঘন্টা সময় লাগবে স্যার, 8টায়। আমি আপনাকে লিঙ্কটা পাঠিয়ে দিব স্যার।
আমি লিংকটা চ্যাট বক্সে শেয়ার করছিলাম।
একটু বাইরে যেতে পারি।
আচ্ছা স্যার, আচ্ছা
বাসায় থাকলে করবো।
হ্যাঁ শিওর স্যার,
আচ্ছা।
শিওর স্যার। ওকে,
আসসালামু আলাইকুম স্যার।
ওয়ালাইকুম আসসালাম। ওকে, দেখা হবে ইনশাল্লাহ আবার।
আসসালামু আলাইকুম।
থ্যাংক ইউ।